is time for the panel discussion. Now, without further ado, let's welcome our esteemed panelists. Each of them brings a unique perspective and wealth of experience to our discussion. Please join me in welcoming Dr. P. Vijaya ma'am, Director Neuroscience Department, Lalita Hospital, Guntur; Ms. Gracy Mathai ma'am, CEO, Baby Memorial Hospital; Professor Elizabeth Varkey ma'am, Deputy Chief Nursing Officer and Professor, Baby Memorial Hospital; Dr. Chandran, Professor of Physical Medicine and Rehabilitation, Government Medical College, Kozhikode. To guide us through this insightful conversation, we are fortunate to have an experienced and skilled moderator. Please join me in extending a warm welcome to our moderator for today, Dr. K Rana sir. Welcome, sir. Over to you, sir.
Yeah. Thank you. Thank you very much for giving me this opportunity again to moderate this session with eminent stroke experts. Dr. Vijaya, I know that her hospital got the first accreditation for stroke in the country, and brings a lot of insight into things. And then obviously Gracie madam is there on top of driving the nursing, and then now driving the organization as a chief executive. So it's, and Professor Elizabeth and Dr. Chandran. So it's about stroke challenges in stroke management. So I'll come to each of you and ask quickly that how first question I would be asking, do you have any challenge in treatment of stroke? So that's the first thing. Okay. Do you have any challenge in stroke management?
Of course, there is a challenge because it's not one particular person's responsibility. It's a group of people. Everybody's involvement is there. That's the main challenge. And it has to be a coordinated as well as a cohesive one. Okay. Dr. Vijaya, what's your take?
That's from the healthcare workers' point of view, but equally challenging is what the patient thinks, what the attendants think, and they believe. There are a lot of still myths and misconceptions that they still want to go for Ayurvedic or other local medications. Once we say brain stroke, they say if it is stroke, we can, that is better, isn't it? They will ask us. So still there is a long way to go for patient education, and now it's much better with so many awareness programs year by year by the Indian Stroke Association, by the World Stroke Organization and the local people, increase in the awareness, and especially the treatments. We should be taking the treatments to the public again in time so that they are effective. That's the main challenge. And the second thing is a little bit of financial constraint that why people have. As more and more people get covered under insurances or other health coverage, we can overcome this also. The perception, the recognition, and the belief in the medicine treatments is one thing. And the third thing is the financial things. All these are challenges from the patient point of view.
Good, good. Thank you. Yes, Elizabeth, what about your take?
Yeah, well, thank you for this panel discussion and for that. In my perspective, when we go on to the nursing care area, because I'm on the Deputy Chief Nursing Officer, we face a greater challenge, especially in management of patients and management of the nurses even, because all of you might be facing the challenge of attrition even. So when we provide the best education as well as the same is related to stroke management, we are unable to retain them, we are unable to maintain the pace of the experience and skills that they need to manage a patient. So that is the drastic thing that we are facing and the most great challenge that we are undergoing through.
Great, thanks, Roy. Your take?
Good evening, sir. Respected Rana sir, thank you for the opportunity, and thank you VGP sir for the invitation. Yes, sir, we have probably the PMR department has got the greatest challenge because you know that even with the recent advances in stroke management, it significantly reduced mortality and morbidity, but still even in US, 30 to 40% have significant disability. But in India, I don't know, we don't have the actual statistics, but we only have almost 150 qualified PMR departments, rehab centers in India, and less than 1,000 rehab physicians, the physiatrist. Another thing is regarding the cost of treatment. In our department, the Kozhikode Medical College PMR department, the rehab center have almost 70 staffs, the doctors and paramedical staff. And And you know that what will be the cost of treatment if it happens in a private institution. And another thing is the cost of treatment. So now we have robotics and virtual reality treatment. It is not affordable to the poor, because even in Kozhikode, we don't have, even in Kerala, we have only one G-gator, that is newer thing, and neuro rehab, the robotic gait trainer. We have only one G-gator in the government sector, that is in Trivandrum. Not even, we have got 6 medical colleges in government sector with PMR departments. No one have got this recent advances in rehab. That's probably the cost, and the long-term rehab is the main issue, sir.
Okay, great. Thanks. So you four have actually covered some of the components related to patients related, some are cost related, some are, you know, facility related. Now I'm coming to some of the clinical aspect of stroke management, maybe from the nursing perspective, from the administrative perspective, or from a clinician perspective. Patient comes to your hospital for a stroke, you recognize stroke. Now how to arrive at a conclusion, how to arrive at a decision that what care actually is better for the patient, whether it's you recognize that something has already gone beyond your hand. Okay, I'm just expanding this area, but still, can you do something? Or because this is also related to some of the ethical aspects of the care, you know, how individual practitioner, how in a hospital actually, and at the end, it become a challenge for the organization, whether we could not provide the care to the patient, we could have, but we didn't. We could have provided something, but we didn't. We wanted, but it happened because my team did not agree. As a core team of stroke management did not agree to the same protocol which I wanted to execute. My director did not agree to me. So there may be different challenges around, you know. So my question is to Dr. Vijaya is, in your setup, when you really look into the clinical aspect, how you arrive at a decision as a team that this is what I'm going to do, or we are going to do this patient.
Actually, very good question and very relevant, because there is so much research and evidence now. We have a solution at every stage, as you say. For example, the TIA, the TIA stage, where you have only transient symptoms, and they are not supposed to ignore it and come to the stroke center. Then we investigate them and try to prevent the first stroke. That's the best opportunity. We have now with the imaging, great MRIs and Dopplers available in most of the hospitals, and they have a protocols. TIA management gives us the opportunity to stop the stroke in the very beginning. And when they go on to the next level of acute stroke within 4.5 hours, so-called golden period, again, if they can come to a stroke center, primary or secondary, or even an ER physician trained in stroke care with a CT scan, just a CT scan, and they can be trained in the network of these stroke centers to give IV thrombolysis, which is the best medicine so far across the world. And if they come beyond 4.5 hours and still within 24 hours, we have a protocols and evidence for a thrombectomy, and which can be done in the advanced stroke centers for most of the patients, except the financial part. And some of them are covering this one also. PMJY is covering in some of the states, I believe, and in government hospitals in Kerala. So clinical part, if I think, this is the best time for stroke patients. So we can, first of all, prevent the first stroke and stop the progressing stroke and deal with a massive stroke. And if they come beyond, as you said, the whole half of the brain is gone. Previously, we used to give up on them. Now we do decompressive craniectomy by the neurosurgeons, and we can save them. And most of them do recover to a reasonable functional status. So overall, with so much of evidence and treatments available, this is the best time for stroke patient. Of course, the earlier the better. And even at every stage, any stage the patient comes to us, we should be thinking, as you rightly said the question, what can be done to this particular patient at this point of his disease? There are many things. And there is again secondary prevention. Once they come out of this first stroke, we know what to do to not to get into the second stroke. It's a lifelong journey together with the patient. And little bit awareness, little bit counseling, and little bit of medicines.
Thank you. Fantastic. I think that's a whole bunch of solutions which you have put into one bouquet, for the patient. And I will come to Gracie, madam, from the perspective of, I would say, administrator perspective. When the team in the stroke division or center is looking for some aspects of managing a stroke patient in terms of resources, right? And you are not convinced. You are not convinced. So, but stroke team is convinced and asking that we need it. If you want us to provide the best care to our patient in stroke, this is what we need. How you get to that? Do you surrender or you say, no, I am not interested. Please forget about it.
The first thing, I'm not that type of an administrator, because I also understand the requirement of a stroke patient and what should be the outcome. That also I am very well aware. As you know, in my hospital, I have about some 12 clinicians are there. Interventional as well as other non-interventional 12 clinicians are there. And especially when the stroke things came forward, they wanted to start the stroke unit as well as they wanted to go ahead for the accreditation. So my first thing, I sit with them and I did the strategic planning, how we can go ahead and all those things. Because I call each one of them, rather first Dr. Pradeep, and then of course the group and the interventional group. I have called them and I asked them, okay, what all requirement you require? Then we sat together and we have developed the policy, because policy need to be prepared because everyone have to follow the policies. So the development of the policy have been started with the help of them, as well as the nursing, as well as the rehabilitation group. We have developed the policy. Of course, the next thing the question asked me is the allocation of the resources. So I have to allocate the resources. Clinical resources are there. What about other resources? I have to have a stroke unit. I should have facilities and the equipment for my stroke unit. I should have nurses for my stroke unit. I should have other associated people for my stroke unit. Of course, MRI, CT were already over there, so I need not go for that. It was already there and functional with all those things like, and the staffing is there, but the training of the staff was most problematic at that particular time, because training is very much important, because we are not in a position, or they don't know what first step need to be taken, what should be the next step. So training was really additional problem, but anyway, we could do that. And then of course, ultimately, what we do all these things for little higher recognition for going for accreditation as well as the statutory compliance. So thus I could go for accreditation, and I could see that my hospital is the second hospital, and Dr. Vijaya hospital was the first hospital, and I could see that my hospital was the second hospital to be accredited by QI on a stroke accreditation. That's what. Now what I am facing again, one of the problem is the engagement of the patient and the family, because like Dr. Vijaya was very clearly said, now patients, their attribute, their feeling, their knowledge, they all look into various aspects and they come to us. So we have to engage them in a proper way, so that the proper education is being given to them also. When I say engaging, I'll see that little involvement of the patient relative in the care of the patient. Because stroke patient, it's as Dr. Vijaya has very clearly said, it's not going to cure within 1 day or 1 month. It may be a long disease so where they may not be able to admit in a hospital for a long period. So they have to take care of them when they go home. So the engagement of the relatives in taking care of the patient, as well as the patient when they go home, those I'll say again other my challenge. Now what challenge I am at the moment, I'm again feeling that now since I have accredited and then some 4 or 5 months passed, now very shortly I'll be completing 6 months. So I need a data for reporting into the national as well as the international way. I have to collect the data reporting, and one of my person I have already assigned that it is your responsibility to collect the data and see that that will be reported in the national as well as the international things like that. And as Dr. Vijaya has again very clearly said, public knowledge, public awareness, advocacy of that. Even that one of the speakers, Dr. Nirmal, was also very clearly telling, you have accredited, but the public should know that you have been accredited. Your hospital is the best hospital. When I go over there, I'll be getting the best treatment. So that is my next thing, to see that how, though I have done various marketing things have been done, social media, all those things have been done. But again, I would like to see that more information need to be given to the public. That's what I am looking into. Of course, it's all a challenge as an administrator.
Absolutely, absolutely. We wish every administrator become like you and provide resources to the centers, which actually ultimately brings to the organization.
Yes.
It's ultimately for the organization, for the patients, for community, everyone. Now, I will reverse the question for Roy and Elizabeth. The question I will for both of you are, first Elizabeth, is you need to get resources from your administrator. What you will do to get the resources? what strategy you will apply, you use to get the required resources for the care which you want to deliver in your hospital.
Okay, for me also, as Gracie ma'am already mentioned, she's a perfect administrator and we don't face any challenges when we need resources at the time. At the same time, we have a great support with the management, and when the need is being put forward, it is being granted also. Moreover, we have various forms of resource planning in which we calculate the acuity score based upon the patient needs and the resource requirement for such a patient who has high dependency of care and stroke. So we also have classified some people as the stroke coordinator, the counselor even, and we have designated them accordingly. So the most important thing that we have seen, especially the nursing care is already there, but I think the resource that we need to more involve is in the aspects of the psychological impact. And for that also we had some counselors even. So this basically we have seen many of the time when the patient is admitted in the ICUs and when they are about to be discharged or when we talk to them, they are becoming so depressed. And moreover, like when we communicate, the nurses are being frequently emphasized to tell them about motivating them, saying that others are waiting outside, come up. So this is a kind of motivation that is being given. So I think there is a need for a counselor also. So all those things we are on the plan and this has been given to us. And I think because this is an important area where immediate attention and the crucial time is there. So the nurses has to be in a pace and they should be able to understand what are the various things that has to be taken care of. And then we need a chain of people. So resources in a sense, I think because and this is understandable by a administrative perspective on the CEO, definitely it is being provided and we are on the pace of having these forms of professionals.
Thanks, Elizabeth. Roy.
Yes, sir. So, according to the definition of neuro rehab, it is a complex medical process with aims at aid in recovery of the nervous system. But we need to train and retrain the individual. Train and retrain. For that, we need, as I had already mentioned, several paramedics, our friends like PTs, physiotherapists, occupational therapists, rehab nurses, psychologists, and piano technicians, etc., etc. So several staffs. So unfortunately, in the post where I am working, we have got only three therapists. Only three therapists. Only a lady therapist extra for because we have three male therapists. The STS have given us a lady therapist for managing the lady, the victims of stroke or neurological conditions. So the rehab should start from the day one itself. Day one. So actually, we need a therapist at the ICU itself. So I think it is not possible to have a therapist in the ICU. That means 24/7. That is not possible. So the important thing is we can train our nurses. They're excellent. They're excellent students. They will care the persons excellently. So we used to train our nurses. They will give quality care in the initial phase itself. And another best therapist, the bystanders. We can train the bystanders. We used to train the bystanders for giving some exercises. They will do it in perfection. We should say it in perfection. Especially wives. See, wives are good nurses and good doctors, not husbands are. But wives, if that is the statistics have shown that when a lady is disabled, the recovery is less than a male because for a male there is a wife who is a good nurse and a doctor. So we used to train our bystanders and the staff nurses regarding the rehab. That is how we will manage the gap between the lack of therapists and the need.
Okay, great. Thanks, Roy. I think the important point which I feel in the stroke care compared to any other disease is that it requires an approach of integrated care. It's not just neurologist or stroke expert is sufficient. No, you cannot get the result unless there are integrated system put into place like rehab or counseling or psychologists or physio, whatever you need. It is a integrated system which you have to really work together. If you have to actually write a individualized care treatment program for each patient. Each patient needs might be different, and then you have to write it. Yes, this is my job as a neurologist. This is your not job as a physiotherapist. This is your job as a counselor or psychologist or so on. And here's your family as a family, and your job as a patient. You have to also follow what we say. Otherwise you will not get the outcome which you think patient can achieve. So I think it's a very great example of integrated care within the multidisciplinary approach for achieving the thing. So before concluding, I will each one of you ask you if you want to give a message to community, what that message would be in relation to stroke care management.
Okay. For the community, first of all, recognize brain stroke as an important disease, and it can happen to anyone, anytime, any age. Learn the signs of stroke. In case you suspect stroke, don't delay. Reach a stroke center immediately. For that, you should have the information before. And follow the doctor's advice and get back to normal life. And lifelong, as I was mentioning, once you are out of that, still there is much more for stroke. You have to take precautions in the form of lifestyle changes and regular medication, regular checkups is lifelong treatment not to get into that zone again. In case by misfortune you get into once, you need not go there again. And there are enough medicines and enough evidence-based treatments to protect you for a long time to come. Along with our multidisciplinary team of neurologists and nursing and physiotherapists and the counselors and social workers, we can get you back your life after the stroke.
Thank you, madam. Thank you. Very nice. Very nice. Dr. Gray.
And to add what Dr. Vijaya has already said, what I want to say, but still to add that one of the most important things, recognize the early symptoms of the stroke. See, if the delay, what will happen, that they should understand. Early attention, early seeking medical management or hospital care or doctor's attention, that they have to understand. They should not wait for anything. Okay, now mild thing is there. Okay, tomorrow I will go, day after tomorrow I go. So a public education, I think it's our responsibility, not only even though accredited hospital or non-accredited hospital, any healthcare organization, I'll tell you, it's our responsibility to educate the general public. Because this can occur even today to you or me. Anyone can occur. So how to recognize and early recognition and early treatment. Again, people may be worried, oh, once I have come stroke, it is going to be there for now years and years. No, it is curable. It's only you and I have to take part in it. If the patient feels that, no, it is nothing, it's only a small thing, I will take part and I will be cured, it will be cured. It won't be a long-term thing. Like I know n number of patients who have cured and working like a normal person like. So they should not take it as a big thing. Even the family should not take it, oh, now everything is gone, no life is there, life end over there. No, life only just begin from here. From here they have to see that their lifestyle, all their lifestyle things also will be changed, and they follow the rules and follow what is the instructions have been given by the hospital or the doctor, and recurrent visiting the doctor. Not that even though the doctor say, okay, you come once in a month, they don't come once in a month because the symptoms subside and they don't come. No, here they have to come. Once the doctor has said, it is not for the consultation doctor calling you. It is for your purpose though. So they have to follow up the instructions strictly. That's what I would like to tell the public.
Thank you so much. Very, very, very pertinent. Elizabeth.
One thing I would tell to the community is just the time management, especially during that golden hours, the importance of that golden hour in taking the patient from the door to the needle. So that has to be made aware about for the, especially for the relatives as well as for the patient. And second thing, I would emphasize on the importance of dealing the rehabilitative perspectives. Like as ma'am also already mentioned that they all feel that it is just the end of a life or something like that. So we can have some stories of life experiences of patients who had undergone the stroke. So that would really motivate the people who will be the victims of this. And finally, one great message: they will have miles to go before they sleep. Thank you.
Fantastic. Thank you, Elizabeth. Thank you, Roy.
So India is a fantastic country. Where in the world can you see this much of types of cultures, languages, food, etc., etc.? And it is also a wonderful country in that we have got almost 7 recognized systems of medicine and 30 plus unrecognized systems of medicine. So like any other chronic disease, we used to get patients at a later stage. So we also had a golden hour of first 3 months. In first 3 months, if you give them proper rehab, the proper brain plasticity can develop, and 90%, 95% of the recovery happens in the first 3 months, and maximum 6 months. So another study have shown that if you start rehab in the early days, you can increase, you can have the plasticity modulation to another 1 to 1.5 years. So the recovery can be extended up to 1 to 1.5 years. So my message is actually any stroke patient will come to a modern medicine hospital. So we have a golden hour there to educate the patients and the bystanders regarding the modern rehab techniques. So start early and they will continue the rehab. Thank you.
Thank you. Thank you. All of you have really made important points. First is engaging patients. Second is about recognizing the symptom stroke. Third is about seeking the medical help for that. Fourth is about don't waste time. Don't postpone it to tomorrow, day after tomorrow, which our tendency is. Sixth is about, don't lose hope. It's start of your next life. Seventh one is actually how you ensure that the patient follow after care of the stroke, that they like rehab or something. Don't consider that as an extra burden or something. I may not need it. They just said it, I may not need, but patients should understand that is the most important thing to recover what he or she can get it. So I think these 7-8 points you all put together in nice manner, and I think our people who are listening, and they will also perpetuate in to the other people who they meet to. So thank you each one of you for your wonderful deliberations, and we learned a lot from you. Thank you very much. Please keep continuing your good work which you have been doing, and your thought process as well. Thank you. Thank you. Thank you.
Thank you, Dr. Rana, to you also.
Thank you, Dr.
Rana.
You know, moderated
Great
it well.
moderation. Thanks, everyone, Madam Gracy.
Thank you. Thank you.
Elizabeth,
Thank
Madam,
you, Rana sir,
and
Vijaya ma'am,
Dr.
Gracy
Rai,
ma'am, Elizabeth ma'am.
and everyone. Yeah.
Abhinav.
Thank
Yeah.
Thank you.
Thank you, Dr. B.K.